Foy White-Chu. Oh, let me share my webcam. My apologies. So I'm Dr. Foy White-Chu. I'm a geriatrician and a wound healing physician here at the Portland VA Medical Center in Portland, Oregon. And I'm also an associate professor at Oregon Health Sciences. And what I want to talk about today is to really focus on some preventive strategies and also some policy that came through that was passed to help our older adult patients struggling with edema and infections from that. So let's get started. I have no financial disclosures or other conflicts of interest. So the objectives, I want us to learn how to recognize venous hypertension, outline some low-tech strategies for our older adults to use as an early intervention, really focusing on prevention and some treatment, and determine when to refer to a wound healing center for vascular interventions or rehabilitative therapies. So what exactly is venous hypertension? When I'm talking to my patients and trying to explain this, we have vessels, veins, that take the blood flow from the foot back to the heart. And the way this works is we have valves in those veins so that when the the muscle contraction is not happening, the valves snap close and prevent the backflow of the fluid into the extremity. In this case, what we're talking about are legs. However, sometimes we will have incompetent valves, and that can happen for a host of reasons. Older age is probably the most common reason, as well as working in jobs that require a lot of standing or prolonged sitting. If you've ever had any surgery in your leg or a deep venous thrombosis. And also if you're female and happen to have a lot of children, that also can increase your risk. But even we've noticed that as people get older, the female to male ratio of seeing venous leg ulcers and venous hypertension evens out. So it's not necessarily only women. So we're seeing these increased venous pressures due to inadequate muscle contraction. So I'm going to talk about how we target that, as well as incompetent veins. And then the other risk factors that I mentioned before, including those patients living with heart and kidney failure, having a lot of fluid in their extremities and overwhelming the venous system. So how do we recognize venous hypertension? It's one of those, well, you know it when you see it, but there are some signs you can look for. So in the upper left here, you'll notice that the patient has some spider veins. That's really common kind of at the beginning. The upper right, especially on that left leg, is a really large varicose vein, and that's very obvious. You'll see it, the tortuosity around the calf and also into the ankle. On the bottom left here, I want you to focus on this white hypopigmented area. And then there are some little red dots in here. This is called atrophy blanche. Essentially, this is a non-specific finding with venous hypertension. It's exquisitely painful, and patients have a real, like a hyperesthesia. They're very sensitive to any touch in that area. Again, it's non-specific finding and not everybody has it. And then another finding we might see with venous hypertension is lipodermatosclerosis. We're often taught to look for that inverted champagne bottle deformity. And so that means this narrowing at the bottom with a widening at the top. And when you press on this leg, you don't get pitting edema. It's very wooden. So the derivation of the lipodermatosclerosis, lipo meaning fat, dermato meaning skin, sclerosis, scarring down. So what's happening is with that chronic inflammation, and venous hypertension is an inflammatory process. With that chronic inflammation, you'll have scarring down of the tissue underneath the skin. So we're constantly telling our patients to elevate their legs above the heart. But where did this whole let's elevate our legs come from? Well, there are two studies I want to point out. One was a study done in 1994 that when I looked to really, I was just doing some reading, and every time someone cites a study, it was only 30 patients total. They had 15 patients with venous hypertension and the associated chronic skin changes like we saw in the earlier slide, and 15 patients without. They studied those microcirculatory flow velocity and the chronic skin changes. What do you think the results were? Well, it showed that if their legs were down, then they had worse flow back to the heart. So that, again, very small study, not entirely practical in terms of application for our patients. So I want to bring your attention to a 2011 prospective study. And this is where they actually took 80 patients who had a venous leg ulcer, but it was closed. And what they did is they initially looked at their medical records They looked at their physical activity, nutrition, self-report questionnaires on these activities, preventive activities, psychosocial measures, and then they followed up with them every 3 months for 12 months again after their closure, and found that during that year, 35 of the 80 patients had recurrence. And so they tried to find out, well, who had less risk of recurrence? Those were patients who reported at least an hour a day of leg elevation, but they're reporting it. So what exactly are they doing? Are they sitting back in the recliner and kind of elevating their legs, or really getting it above their heart, which causes back and hip problems? It's really challenging. Those were in compression stockings 6 days a week. Great, but what millimeters of mercury? They weren't following any of that kind of granular detail. But also I want to bring to your attention higher social support scores and higher general self-efficacy scores. Like they felt they were able to do more for themselves. And that kind of comes in place in terms of when we're thinking about policy for taking care of some of these patients, especially our frail older adults that don't have social supports at home. So I roll my eyes when I hear, oh, I was told to elevate my legs, and so that's why I'm not exercising. We do a real detriment to our patients when all we do is tell them to elevate their legs and not get moving. Use it or lose it is what we say in geriatrics. Okay, so let's talk about those low tech strategies that I mentioned. Really thinking, what I counsel my patients on, whether they have an open wound or not, is some kind of physical exercise. And I try to meet the patient where they're at. I love prescribing walking. It's cheap and easy to get out the door. There are places where people live, either unsafe neighborhoods or they don't have sidewalks. That could be a real problem in terms of, getting hit by a car. Other options, though, is if they have a local area, maybe a mall or a park, someplace that they might be able to get to. Other ideas would be a community center with maybe a treadmill, or for those who have really bad knee, hip, and back issues, is riding a bike an option for them? Again, need a bike-friendly city or area to be able to do that. So I'm constantly just saying, well, what activity do you do? And like, well, I walk to the mailbox. I'm like, great, how far is the mailbox? Oh, about 300 yards. That's actually pretty far because of people own property. It's like, okay, well, can you go to the mailbox twice a day? And they kind of look at me like I'm crazy. I was like, if you can go once a day, then maybe you can go twice a day. And that's some kind of aerobic exercise to get you out the door. Okay, but with that, we also talk about calf raises. Again, I'm talking about this with patients both with and without leg ulcers. I'm going to show you an after visit summary that I typically give to patients, normally starting in a seated position. But the calf raises really work on that calf muscle and its impact on the deep venous system and helping with blood flow back to the heart and consequently reducing edema and complications. Okay, so how does this exactly work when we're looking at this exercise for leg ulcers, what they call working out the nature of venous ulcers? So on the left here, you'll see that the leg is completely relaxed during ambulation. You have the superficial system where the blood is filling in through these veins. The valves are open. It's going into the deep system, but the valves are closed, as they should be, to prevent retrograde flow through the deep system. Then we walk, we push on that calf muscle. That then changes the pressures to where the superficial system snaps closed, but then the calf muscle overcomes the pressure of the valves and pushes the blood flow back to the heart. So that's what you want to see. And what we're constantly trying to help both the calf raises and a walking program or some kind of aerobic exercise to really strengthen those muscles. So in terms of like really looking at higher quality data for why I counsel patients with leg ulcers on both exercise and progressive resistant exercises, those are the calf raises that I was talking about. So this was a meta-analysis and a systematic review that was done back in 2018. There were 6 studies that qualified for evaluation. And this was looking at any healing outcome. Secondary outcomes were adverse events, cost, quality of life, etc. So you'll notice with the progressive resistance exercises, so this is calf raises only, it kind of falls in the middle. Maybe it helps, maybe it doesn't. Then walking 10,000 steps, maybe a little bit better. Maybe it helps, maybe it doesn't. But the combination of those progressive resistant exercise and some kind of aerobic physical activity definitely pushes in favor of exercise and helping with wound healing. So I'm constantly asking patients when they're coming back to see me, how are you doing on your aerobic exercise? You know, whatever that exercise, you know, are you doing your walking? Are you doing your pedal on, you know, your desk peddler? Are you getting on your bike, etc. And doing your calf raises? Okay. So this is the after visit summary that I was mentioning. I do talk about a walking program again because it tends to be the least expensive modality. I even talk to them a little bit of doing 10 minutes 3 times a day. Patients will often say, well, I can walk, but I have to use a cane or a walker. That's fine. This isn't about balance. This is about aerobic activity, and it's not considered cheating to use a walker or a cane, especially for our patients with heart failure. That walker can be very helpful if it has a seat where they walk a certain distance, and if they're getting tired, they can sit and rest and then continue to walk. And I do talk to them about using that heel, pumping that blood up from the foot. Then they elevate your legs. So there is leg elevation as part of my program, but it's not all day, every day. I still want them moving. And then these progressive resistance exercises. I start with them seated, doing the heel rises in both legs, and you'll see increasing the sets 3 times a day, though. I usually say we'll do them, you know, around meal times if you eat meals 3 times a day or something else to that effect. And then stage 2, they're standing. And again, this is not a balance exercise. So I do tell them either a sturdy chair or even tell them a countertop to stand on top, stand near, to help them really for strengthening, not for balance. Well, they're holding onto the counter for balance. But again, they're doing this exercise for strengthening. And then for those who I think could manage it, the one-legged heel rises, if they're pretty significant falls risks, then I'm telling them, don't worry about that. Just do stage 1 and stage 2. So we have a lot of compression choices out there. In the left here, these are ones that, you know, you can find on Amazon or some other retailer. And usually they're anywhere from 10 to 20 millimeters of mercury over the counter. And they're actually quite effective for just mild edema. And I do encourage patients to consider these when they're having some problems. This garment, which we're going to talk a little bit more about some policy changes recently, this is a Velcro compression garment and could be really great for those older adults who have either dexterity issues or arthritis issues in their hands, or maybe they can't pull on a 20 to 30 or 30 to 40 prescriptive compression garment. So there's a lot of choices here. And garments are used for prevention. Rarely are they used for treatment. There are some exceptions even in my clinic, but please keep in mind that this is for prevention, no open wounds. So there's an added benefit that one of the infectious disease colleagues here at my work, and I got very excited about this study that came out in 2020. So this looked at chronic swelling of the leg as a risk factor for cellulitis. What they did was a single center, randomized, non-blinded trial, and they assigned patients who have been admitted for recurrent cellulitis, where 84 were enrolled, 41 were assigned to the compression group, and 43 to the control group. So the compression group, everyone got education on cellulitis, educated what was it about, hygiene for prevention, and those types of modalities. They also, one group also received compression therapy on top of the education. And the follow-up occurred every 6 months for up to 3 years, or until 45 episodes of cellulitis had occurred in the trial. And what actually happened is when they did an interim analysis, there were 23 episodes of cellulitis that had occurred. Only 6 in the compression group, that's 15%, and 17 in the control group, that's 40%, had an episode of cellulitis, to where they actually stopped the trial early for the efficacy. And this is a pretty dramatic Kaplan-Meier curve where this is the control showing percent of participants free from recurrence. So these guys really were staying free from recurrence while these were not. So it's yet another take home of the importance of why we should be paying for garments for patients with swelling and risk of cellulitis. And I'll get more to that in a bit. So there it is. I'm getting to it in a bit. This was so show me the money, the Lymphedema Act. This is an act that multiple wound organizations and lymphedema associations have been really pressing, like, for well over a decade to push through Congress, because prior to this, if you came in with a venous leg ulcer and you closed it, there was no way that nothing was going to pay for the garment afterwards. And these garments have to be replaced about every 6 months. They're quite expensive. And for those who are suffering from phlebolymphedema, which I'll explain in a minute, they're extremely necessary to help them stay out of the hospital and stay functional. So finally, this was passed in the omnibus package back in December, part of the Consolidated Appropriations Act in 2023. This improves Medicare insurance coverage for the medically necessary clinician prescribed compression supplies for lymphedema. It will go into effect in January 2024, and during this year, Medicare is working with patient advocates and stakeholder groups through 2023 to determine what's actually covered. But wait, I thought we were talking about venous hypertension. So this came up. I was actually talking to a vascular surgeon the other day. I was doing some teaching with nurses on this very issue, and I was talking about the passage of that act, and he was very impressed. And I said, this is where it's going to be so important for us to figure out, because a lot of the patients have some amount of phlebolymphedema. There's not a really great, there's not a black and white, there's not like a blood test for it or an imaging study that's low cost and easy for it. It's a clinical diagnosis. And some people have lymphedema that comes and goes. So determining who's going to receive these garments is going to be crucial and really key. So you'll notice on the right here is your lymphangium. So the lymphatics are yet another, you have your arterial system, your venous system, and then your lymphatic system. And the lymphatics is where, as that extracellular fluid is being cleaned through the lymph nodes and is coming and is draining back into the circulating system, you have these lymphangians that are lined with smooth muscle. So patients with diabetes and peripheral neuropathy, this is one of the reasons they tend to get swelling, because their lymphangians are not being innervated quite well. This middle picture here shows someone doing what's called a test for Stemmer's sign, where they're pinching the skin at the dorsum and the base of the second toe and determining whether their fingers meet. So this is the closest thing we have to a black and white, but not really, test in terms of whether someone actually has lymphedema or not. And then again, going back to what venous hypertension is, and it's quite fluid that people having lymphedema have venous hypertension and vice versa. It can be quite difficult to tease out these overlapping conditions. And these overlapping conditions have the same outcome, so maybe that's where our vision needs to be, that we need to be focusing on all of these patients will suffer ulcers and or cellulitis episodes that are extremely high cost with high morbidity and even sometimes mortality. And so all of these legs have some kind of edema and venous issues. So I wanted to touch briefly on when to refer. Primary care providers have been educated somewhat on managing open wounds. But in terms of a chronic, if it's an open wound that's not healing well, then I would have a low threshold to refer them to a wound healing center in terms of being able to handle the frequent visits and the complexity of what's needed for healing. I often refer my patients either through home health for physical therapy and occupational therapy, or outpatient PT and OT if they're having trouble mobilizing due to either hip or knee issues or back issues, really to get them moving, because like I said, movement, physical activity is key to this. So I want to go on to talk a little bit about venous ablation, because this might come up. There are a couple of trials. There's this one from 2020 that looked at long-term clinical and cost effectiveness of the early intravenous ablation of venous ulceration. Prior to that, in 2018, they were really looking at the efficacy. So I'm going to touch on that. Oh, sorry. So venous ablation, I didn't say what it was. So that's when you have a superficial vein that the valve is not functioning as it should, to where it has more than 0.5 seconds of retrograde flow. And when it has that, you can do an ablation of that vein to allow the remainder of the veins to not have to work against so many obstacles, because as I put it to the patients, the lazy vein's been knocked out and the rest can pick up the work a lot easier. So this study was a 2018 study where they looked at the EVRA ablation trial. They found that ulcer healing was shorter if you got to them early. So so patients are presenting to clinic. On average, the venous leg ulcer was there for about 3 months, both groups, either the early intervention group or the deferred group. The early intervention group were randomized to within 2 weeks to undergo an ablation therapy if they qualified. The deferred group was 6 months, or if they hadn't been healed, and it was deferred for 6 months if they hadn't been healed. So if they were closed, they didn't go into the deferred group. And although it's not as dramatic as that prior study that I mentioned, there's definitely a significant difference that of those in the deferred intervention group, only 75% actually got the intervention within 1 year. But it did show that there was faster time and more time free from ulcers if you were in the early intervention group. So there are plenty of barriers actually that this study even brought to light as well, that many patients seen in wound clinics don't have access to vascular lab to screen their patients. And so that's going to further limit that early intervention. There's also siloed management where the wound clinics don't have incentive to send these patients out for early venous intervention. So when we're thinking about building our future practices, we should think about partnering and really making these wound clinics interdisciplinary. Of course, payment strategies would need to be advocating on a systemic level to support that cost-effective care, which they did find it cost-effective in their 2020 trial. So some policy questions and opportunities. How will the Lymphedema Act be defined, or how will lymphedema be defined under the Lymphedema Act? That's going to impact coverage of compression garments for all. And then I also want to bring you back to the very beginning of this talk where we were talking about how those with better social supports had less risk of venous leg ulcer recurrence. And so thinking about alternative caregiving models, especially for those older adults who don't necessarily have friends or family that can easily help them care for themselves. And I'm always advocating recognizing that home health aid care is skilled care. It's very challenging and also very rewarding, and we really be recognizing this as skilled care. And that is it. And I'm happy to take any questions before Dr. Milnes goes and does her talk. And you can put questions in the chat if you want, if you're more comfortable with that.
Is she still on the room? Hey, Trisha, are you having some issues sharing your PowerPoint?
Yes, let me try one more time.
Okay, no problem.
Oh my.
Oh, we can see it.
There we go.
All right, there we are.
Excellent. Thank you. All right, well, thank you for allowing me to present on audiology services. So I hope that I can provide you information that may help your patients communicate better and live the lifestyle that they choose. Hearing loss is often gradual, and it can take an additional 4 to 7 to 10 years after a person starts to notice trouble hearing before they actually seek treatment. Research is showing associations between hearing loss and cognition, and now some policies are allowing hearing healthcare to become more accessible, and it is important to that other providers know when to recommend exams earlier in the aging process, and particularly when multiple complex conditions are involved, as there may be other factors putting patients at risk for hearing loss. So audiology services are more expansive than typical age-related hearing loss and hearing aids. It's imperative that hearing healthcare professionals advocate for better personal and organizational health literacy regarding audiology services so that we can address issues that fall below the tip of that iceberg. So audiologists are not only here for hearing tests and hearing aids and the occasional cochlear implant, we help with a variety of other chronic conditions. So for example, a lot of people know that cochlear implants exist, but may not be aware of the criteria that would make a person a candidate. So there is an often overlooked population of patients who would benefit from what's called a hybrid device, which still preserves some low frequency hearing and can help patients with poor discrimination without sacrificing all of their hearing loss or all of their hearing that would happen with a traditional implant. So an audiologist would be able to counsel patients and make appropriate referrals if a cochlear implant would be the best option for these patients. Most people associate balance exams and therapy with physical therapists. However, audiology can also provide therapy and objective balance assessments to give a more holistic view of a person's balance system. So if audiologists are integrated early when patients have conditions that increase fall risk, a person may have better interventions and prevent future falls. So within the aging population, it is common for people to think that hearing loss is simply due to aging, but in reality, there are multiple chronic and acute conditions that can affect a person's hearing gradually or suddenly. Conditions that have associations with hearing loss include diabetes, autoimmune diseases, and cancers due to the use of ototoxic medications. So we want to create better health literacy for patients and providers about at-risk conditions that can help patients access audiology services sooner and find the treatment that is most appropriate for them, hopefully leading to a better quality of life. So treatment options may be hearing aids, but there's also other accessories and apps that can help as well. And trying to change the slide. One second. Okay. So a different approach to patient outreach can be framed in the public health pyramid. So this is not a typical model of care that is used in audiology services, but by increasing health literacy for individuals and organizations about the full scope of audiology services, patients can have better coordination of care and opportunities to choose what is important to them. If a patient does not know that a service is available, they don't know to seek it out. So the public health pyramid describes the number of patients within a population who may benefit from the program's services, depending on the model of the outreach. So at the top, at the direct services level, individuals seek out a program's benefits independently. The individual themselves request the services. However, if a patient does not know services are available to them, or if that they are actually at risk, then they can't be expected to seek out those services, even if they are having trouble. So Medicare has opened up this avenue of care for audiology services and does allow for patients to self-refer to audiologists on an annual basis. This is helpful for patients because they do not need to see a physician for an additional appointment to be referred to an audiologist. However, the drawback is that it is possible that physicians will just continue making those referrals, assuming that patients will self-refer if they are having trouble. This may be a challenge in equity, as patients may not know that audiology services are available and warranted. At the next level, at the enabling services level, support services for programming efforts are in place. This may include referral sources from other providers or services that provide opportunities for individuals to participate, like mobile health units, transportation resources, etc. This avenue can increase the uptake of audiology services as other providers help to educate them about their risk of hearing loss. So examples in our clinic include requests for hearing exams prior to cognitive evaluations and for exams within our TBI clinic. At the next level, the population health services level, we create an avenue to see patients that are identified within a specific aggregate. So within audiology at our facility, we have created a surveillance program of ototoxic medications. So when a patient has been prescribed a medication that may affect their hearing or balance, we reach out to the patient and provide education and offer our services for baseline exams and any follow-up care, providing the patient a choice as to whether they want to receive care and on their preferred timeline. We are also putting in place a surveillance system for patients who have new diabetes diagnosis and diabetic neuropathy. At the bottom, we have the infrastructure services, and that actually does have the widest reach because of those mandates and those oversights that can take place. Examples include newborn hearing screenings and OSHA requirements. Other policies include the ability for patients, again, to directly purchase over-the-counter hearing aids and the ability to self-refer to an audiologist under Medicare. However, this is only for patients receiving self-referring for non-acute hearing loss. Hearing exams associated with medical conditions such as ear infections or chronic sinus infections or sudden hearing losses would still require that referral. So using the public health pyramid and the geriatric 4Ms as frameworks for care, audiology does have a role to play for that aging population to ensure that they can live the life that they choose. Sensory deficits, including hearing loss, are potential risk factors related to cognitive decline. Mobility and balance are important for quality of life, but often dizziness is undiagnosed and untreated. Medications that extend life may have side effects of hearing loss or imbalance. And then again, what matters most, audiologists can help engage with patients in social interests and recommend appropriate amplification that may help in different scenarios. This may be hearing aids or, again, other assistive devices. Here are some statistics for you. The National Council on Aging reports that 25% of people between 65 and 74 have a hearing loss that does disrupt daily activities. Half of people over age 75 have hearing loss that disrupts daily activities. And again, it can take anywhere between, research shows anywhere between 4 and 10 years after they have started to notice difficulty. So again, that means that the patient or the person has had hearing loss for up to 10 years before they've sought any help. The CDC reports that in people over 65, 25% of those patients fall each year, and only half of those actually report their fall to a provider. However, once a person falls, they are twice as likely to fall again. Again, with balance, it takes up to 4.5 appointments for a person with a complaint of dizziness to obtain an accurate diagnosis. And feelings of dizziness can impact the quality of life and the sense of independence, and fear of falling can double the risk of falling. So we want to make sure that patients who have low vision, neuropathy, or other issues with mobility, it's important that the vestibular system is evaluated so that because it may be taking on the task of actually keeping that patient upright. And so it's important to know if it is functioning appropriately. So cognitive overload, even mild hearing loss can make it more difficult for someone to self-compensate whenever there's noise in the room, or if they have, if somebody's not talking to them directly, especially in the past couple of years when we have all been wearing masks. Missing those parts of speech, distinguishing speech amid noise, and then seeing those verbal cues can increase the stress and the difficulty processing speech in the brain. By providing appropriate amplification and counseling caregivers about good communication strategies, we can remove some stress on the patient and the caregiver and promote easier listening. And again, this cognitive overload is being researched as a possible reason that hearing loss may be associated with dementia. So how can audiology services impact that cognitive overload? Unfortunately, hearing aids have been considered too expensive for many, likely preventing many who could benefit from even being evaluated. And rightly so, before over-the-counter hearing aids, it was often $2,000 to $6,000 for a pair. Hearing aids also have a reputation for not working and sitting in a drawer despite having been so expensive. So we want to make sure that audiology takes ownership and addresses these issues. Over-the-counter hearing aids became available publicly in October of 2022 and are considered self-fitting. So no medical exam is necessary, no prescriptive formula is used, and again, they are just self-fit. The benefit is that they are less expensive and they may allow more patients with hearing loss to benefit from amplification sooner rather than later, even if they don't see an audiologist. The drawback is that the prescriptive formulas and the equipment to determine that the hearing aid is fitting on target is met won't be available to those patients. That's only available through an audiologist. There also may be medical reasons for hearing loss that's not being identified if a person purchases them over the counter. That can include severe pressure behind the eardrum, fluid behind the eardrum, occluding cerumen. Unilateral hearing losses and sudden hearing losses may be a symptom of a more severe problem, and if they are self-fitting, they may not have that medical oversight. So again, Medicare permits a patient to request a hearing test from an audiologist annually now without a referral. They have also updated their criteria for cochlear implants to include patients with word recognition scores at less than 60% and for unilateral devices, and that's been over the last year. And then again, the FDA has authorized the over-the-counter hearing aids, and again, that's meant to bridge those gaps in care. So specialized audiology services, so gait and balance examinations, patients who are at risk for hearing loss due to other conditions would also benefit from referrals and collaborations with other providers. So whenever we see our patients for TBI, diabetes, we make sure that they are assessed not only for their hearing, but their balance. We do hearing exams prior to any cognitive evaluation so that the hearing loss does not lead to a misdiagnosis. And then we also, again, look at ototoxicity for ototoxic drugs like cisplatin, carboplatin, gentamicin, amikacin, tobramycin, and then also patients who are on furosemide or buprenorphine also have the risk of temporary hearing losses. So gait and balance, considering how many appointments it typically takes to have a problem with the balance system diagnosed, it would be beneficial for audiology to have more referrals for these exams, as we do have several objective tests to help identify causes of imbalance. However, there are multiple barriers to these exams. They are typically available only in large medical centers. Most of the audiologists in private practice do not offer these exams because of the initial expense and the lack of advanced training. So this may be a barrier to patients in a rural area. So multiple objective exams are available that can help diagnose causes of dizziness. We have computerized dynamic posturography, which determines whether vision, gait, or the vestibular function system is functioning appropriately by isolating each of those systems. The VNG isolates the right and the left ear vestibular system specifically. Rotational chair is good because it allows patients to have their balance system evaluated without having necessarily to walk. Ocular motor testing tests the central components of the balance system and has an association with the vestibular ocular reflex. That video head impulse testing, or VHIT, is a screening for that vestibular ocular reflex. New testing on cervical and ocular vestibular evoked myogenic potentials that looks at the saccule and the utricle in the inner ear system and looks at how it functions to detect movement in space going up and down. And then there's the dizziness symptom profile, which again is a codable questionnaire and helps to distinguish patients' complaints into several different categories. So to fill those gaps in care, we can implement population management to identify people who are at higher risk for hearing loss, tinnitus, or vestibular deficits based on other conditions. Again, traumatic brain injury, cognitive decline, cancer, diabetes, and other medical diagnoses we can look at and identify through either diagnosis codes or partnering with other clinics so that we can ensure that these patients receive that testing before, even before they initially notice a problem. So as our population increases in age and people are living with multiple chronic conditions, for people to experience optimal aging on their terms, audiologists can provide services to ensure safety and quality of life. But we must increase the health literacy so patients have a better awareness of contributing factors to hearing and balance disorders, and proactively partner with audiologists and physicians to engage those services and ensure safety, such as those objective balance tests are available to patients as early as they need them. So TBI can have multiple long-term impacts on patients' lives. Often the complaints may be vague and screening tools do not actually pick up on the issue. This group often requires advanced testing to validate their complaints, including testing for vestibular deficits and auditory processing disorders. And then we do population health management, again, for precognitive evaluations. Again, untreated hearing loss and memory loss and dementia can look very similar. The Lancet report on longevity in 2017 and 2020 suggested that hearing loss may be a potential modifiable risk factor in preventing dementia later in life. Note that this is early research and is not considered causal at this time. The Lancet in 2022 showed that objective audiometric measures were predictive of outcome on cognitive assessments. So if a hearing loss makes it difficult for a person to understand the question, the hearing loss may prevent valid results and a misdiagnosis of cognitive abilities. And we have seen a couple of those cases in our clinic. So hearing exams and appropriate amplification should be provided to people undergoing these evaluations. Ototoxic medications, again, we do reach out to these patients directly. Patients who have cisplatin, carboplatin, and oxaliplatin all have the potential to cause hearing loss. Aminoglycosides, specifically gentamicin, especially in combination of vancomycin, can cause hearing loss and affect the vestibular system. Radiation therapy for head and neck cancers often cause fluid behind the eardrums and hearing loss due to that. Again, diuretics such as furosemide can cause temporary changes in hearing. Within our clinic, we do want to be sensitive that these are often difficult times for patients as they undergo these treatments, but we also want to make sure that we educate them about the side effects of these life-saving treatments that can continue into their survivorship. So we offer education and recommendations for testing so that the patients have that information and they can make the decision based on their priorities. Diabetes. So the CDC reports that patients with diabetes are twice as likely to develop hearing loss. Neuropathy indicates the need for balance exams, and diabetes alone has association with hearing loss, visual deficits, and neuropathy, which all can increase the fall risk. So we want to make sure that these patients are seen as early as possible in the diagnosis period as well. So what happens if patients don't have their hearing loss managed? There is hearing loss associated with feelings of isolation and loneliness. This does tend to be more pronounced in women than men. Again, fear of falling has negative impacts on reported quality of life, and limitations to mobility can impact that quality of life. I actually had a patient this morning who came in, had a moderate to severe hearing loss, which is significant, had never received any amplification, had stopped going to church, had stopped going out to eat, kind of stays to himself whenever there's family around because he doesn't want to ask them to repeat himself. Or for them to repeat themselves. So this does impact their quality of life, and it is manageable. And then this is just a list of other diagnoses that are often associated with some type of inner ear damage. I just wanted to make sure that everybody had that available to them. Again, just so that you know and you can consider those referrals to audiology in the cases of these type of diagnoses. And I'd be more than happy to answer any questions for you about our services or any comments that you may have about how audiology can support your service. So I do see a question in the chat box, cochlear. So where are we going with cochlear implants? So cochlear implants are used for patients, traditionally patients with profound hearing losses that have poor word understanding. Unfortunately, whenever you have a cochlear implant, if you do have any hearing loss or hearing left in that ear, once you have the implant, you lose that hearing. And so you have to use your implant in order to have hearing. Now they have hybrids. So what that does is it preserves some of that low frequency hearing and gives them specific enhancement in those higher pitches, which can help with that speech understanding, and it doesn't sound quite as processed. Usually before patients consider cochlear implants, I tell them that sometimes those implants can take a while for it to sound normal, and sometimes it never does sound normal. So even though your family and friends may sound like Donald Duck or Minnie Mouse, you would at this point understand Donald Duck and Minnie Mouse, whereas before the implant, they weren't able to understand them. Now, with that more hybrid type of device, it is a little bit more natural sounding at the beginning. But again, there's different qualification standards that would go into determining what type of device. Any other questions that I can answer for you? Well, I thank you for your time. Please feel free to reach out if you have any questions. I will put my email in the chat box.